Hello, this is John Wasson beginning a session entitled Population Health and Patient Health, Measuring and Acting on What Matters. And there's the rub. My co-presenter is Lynn Ho. A major structural dysfunction of healthcare is manifest in our acceptance of delayed everything, but in particular, delayed information. For example, if it is available at all, information is delayed for identifying patients at greatest risk for costly care. Information is delayed for patient reports about care processes, and pay for process performance relies on an amalgamation of this delayed information. Although information delay may have been necessary in the 20th century mainframe computer days, we now know that ubiquitous and modern communication technologies can make patient-centered information collection and its use a much more cost-effective foundation for 21st century healthcare. This spring, the National Academies of Science, Engineering, and Medicine released two reports, Vital Signs about the wasteful burden of U.S. healthcare quality metrics, and Implementing High-Quality Primary Care about the grim future of primary care in the United States and strategies to save it. Both took aim at quality metrics, not only for primary care, but all U.S. healthcare. Just a few quotes. Measures were deemed harmful, polluting, inefficient, and without return on investment, lacking parsimony. You get the idea. The expert thinks something ought to be done about quality metrics. The expert's recommendations included a smarter hybrid payment formula based on a mix of capitation and fee-for-service, and as the title implies, core metrics. However, details of the hybrid method were not provided, and their many proposed core metrics were those generally dependent on delayed information, belatedly extracted from billing and electronic health records. In August of this year, the Journal of the American Medical Society, or JAMA, published a report entitled Aligning Payments, Services, and Quality in Primary Care. It contained our specific recommendations for both hybrid payments and a meaningful, timely, and useful quality assurance strategy. Harold Miller is presenting the former, that is, the payment alignment strategy, in a session entitled Value-Based Payment 3.0, Patient-Centered Payments. Lynn Ho and I will focus in this session on the quality measurement aspects of the JAMA report. In contrast to delayed quality measurement, the current state of affairs, the goal of the real-time quality assurance from the JAMA article proposed to take advantage of modern internet-based technologies for automatically making what matters to patients a standardized part of everyday care, to immediately guide services, plan resources, and be cost-effective. This is not an impossible dream. It has been proved feasible for many years. And there's the rub of delay, delays, and clutter we will also emphasize. A core health metric that should already be foremost in the mind of every adult patient, clinician, payer, and policymaker is shown here. How confident are you that you can manage and control most of your health problems or concerns? Suppose 100 people have a health problem and feel very confident that they can manage and control the problem. How would those health confident people do when compared to 100 persons who are only somewhat confident or not health confident at all? Not a hard question, really. One correctly presumes that those who are health confident would do better and use less hospital and emergency room or ER care. So now we turn to the question of this diagram. If you had a choice, would you want to be or want your family to be at a health system in which most patients report they are health confident, let's say 70% do, or in a system in which few are health confident, let's say 25% say they are health confident? The distribution on the left shows 600 health service areas across the United States, and to the right, a subset for patients with diabetes. This is how we are actually doing in health confidence around the country at this time. All rational people would choose a health service system that produces the higher levels of health confidence. As corroboration for this choice, at the far right, you can see as one example the impact of that choice on average blood sugar control. The higher the health confidence produced by health service areas in the highest third is better in blood sugar control than those systems that produce much lower health confidence. Indeed, across many nations, patient health confidence is related to the way in which the healthcare clinicians in that system give patients the opportunity to ask questions about recommended treatments, involve patients in decision making, and explain things in a way that are easy to understand. Clearly, health confidence should be an inspirational goal for the majority of hospitals and accountable care organizations that control most health service areas in the United States. When patient care is examined across multiple clinical practices, the model shown here emerges. This model can apply to general practice or any other specialty practice for which patient self-management plays a predominant role. At the bottom of the diagram are desirable consequences of health services and management, ranging from completed preventative tests, engaging in healthy behavior, managing a disease, and avoiding unnecessary hospitalizations. At the top of the diagram are the usual process components of health care. Of note was the observation that over many practices, the process measures were not directly associated with desirable consequences. Rather, the key catalyst for desirable consequences was patients' health confidence. Health confidence is easy to assess. I show here one method used by community health centers to screen all patients. The science is clear that health confidence is a useful proxy and catalyst for patient and provider engagement, a useful proxy and catalyst for optimal professional care and patient self-care, and an understandable, inspirational goal for everyone. Imagine if a hospital or a national pharmacy chain had as its goal, our goal is to help everyone we serve become more health confident. It's easy to understand, easy to measure, and now the question is, how do you act on it? Sadly, we have a long way to go before we realize the potential of a population being health confident. This illustration from a representative national survey by the Physicians Foundation illustrates the fact that health confidence by patients is very low, much worse for the poor, and influenced in no meaningful way by the service delivery system. Shocking? It should be. There's always a rub, however, against any healthcare change. Even straightforward, free quality assurance changes we are describing in this session. Why? First and foremost, the status quo listens to the beats of different drummers, Pounding away are the sounds of payment methods, quantiphrenic process measures, obtuse jargon, and proprietary analytic methods. And if that's not enough noise, there are the cries of those whose jobs would change and the screams of CFOs about legacy systems, sunk costs, and various fixed costs. Change is hard even when obvious cost-efficient solutions are at hand. There are many examples. One, for example, is our own, that 2 decades ago, the very low-cost technological subject of this session was studied in another large controlled trial. The results were positive for the improvement of many problems that matter to patients, yet the method is not widely known or widely adopted. A perfectly justifiable rationalization for maintaining the status quo of quality metrics is that although everybody seems to agree the current quality metric methods are burdensome, reducing the number of measures implies, on the one hand, ignoring aspects of quality that may be important to some patients, or at least some researchers, and, on the other hand, accepting that some quality measures may be of importance to all patients. Is there a better way? Yes. Test the second implication first. Since we already have lots of measures that don't work very well, let's examine the possibility there are a few quality measures that may be of importance or are of importance to all patients. Think of suitcases. The diagnostic labels we give each patient are merely a suitcase containing a jumble of symptoms, associated illnesses, aggravating lifestyle challenges, health-related concerns, functional limitations, and social factors. But for anyone to manage a suitcase, they need one thing, a handle. Focusing on a few common measures of what matters provides a standard and expedient handle for a generalist or specialist to move each patient's suitcase toward the patient's desired destination. What are those common measures that should comprise the handle? Clearly, health confidence is one, but health confidence does not exist in a vacuum. Several other common problems have a great influence for its attainment or detriment. After years of investigation and insights from practices and patients, 4 additional items are added to health confidence and combined in a What Matters Index. The items are all concrete, easy to translate and understand in multiple languages and cultures, directly stimulate action, and when summed, help clinicians immediately identify the risk for future costly care. These items are, during the past 4 weeks, how much have you been bothered by feelings of emotional problems, such as anxiety, depression, irritability, or sadness? During the past 4 weeks, how much bodily pain have you generally had? How many prescription medicines are you taking more than 3 days a week? Do you think any of your pills are making you sick? And of course, how confident are you that you can control and manage most of your health problems? The responses in yellow are of concern, and each item with a yellow response is summed to produce a What Matters Index, or WMI, with a range of 0 to 5. In addition to each item being a guide for fundamental issues that matter to patients, the sum of 0 to 5 is a useful way to segment or stratify patients for the risk of costly care. Trusting something simple does not mean that clinicians and patients are simpletons. And by taking on the status quo, clinicians who use a WMI should not be assumed to be tilting in a windmill. Instead, they're testing a hypothesis. For example, a scientific test of the What Matters Index ought to show that it is reliably associated with an important patient outcome. Here we see that it is strongly and reliably related to patients' future use of costly emergency or hospital care, something patients, health professionals, and payers all agree is very important. This diagram illustrates the predictive power of the WMI in private practices for chronic conditions, far left, Medicaid patients without chronic conditions in the middle, and Medicaid with chronic conditions on the far right. Gray versus blue is always a big jump, so we customarily suggest that patients with a WMI of 2 or higher receive special attention. And by the way, the predictive power of the WMI has been shown to be as good or in many ways better than risk models generated from the EMR or administrative data or other forms of artificial intelligence. It is very helpful to have the score in real time, understand the items that are causing its elevation, and know that the patient has already had a specific heads up while completing the WMI. Compare this with the current practice. A list of patients is belatedly sent to a practice by a payer whose black box algorithm formula using months or year-old administrative data has identified patients supposedly at risk. Not surprisingly, since the data was dredged by the mainframe computer perhaps months ago, the clinician will find that some of the patients have already died, others have already used costly care, and others will have gotten better. A waste of money and clinician time. In addition to calling attention to medication, emotional, and pain problems, this slide illustrates why the What Matters Index provides a useful handle for other important issues that matter to patients, healthcare providers, and payers. We illustrate in the blue column the responses of patients with a WMI of 0 versus those with a sum of 2 or higher that places them at higher risk. Not surprisingly, these results support the expected association between the WMI and the model for quality assurance measures we described earlier. The What Matters Index is a concise, understandable indicator of important and common needs, is an indicator of quality of life, immediately forecasts costly care, and stratifies patients and populations by need, immediately stimulates action on each identified need, is easily automated with informative feedback for patients and providers, and in our howsyourhealth.org version automatically also collects a validated overall measure for quality care, a validated measure for financial status, and optional queries. Elements of the WMI have been part of the howsyourhealth.org family of standardized assessment and information networking technologies for use on the internet. Designed 3 decades ago to place healthcare providers and patients on the same page, these, as they're called, saints, have been tested and continuously improved so that they are easy to use and free, available on modern devices, provide important information immediately about what matters, are customizable, stratify respondents by risk while placing their information in a searchable registry, and the output, as you will soon learn from Lynn Ho, can support payer, provider, and patient objectives for quality assurance, a learning health system, and accountability. In addition to their use in ambulatory care services, these How's Your Health Saints have been used in settings ranging from very young in school, hospital settings, and even the elderly can use them for home care. Here you can see the type of output a patient receives automatically prior to seeing their clinician. Note that if on the What Matters Index patients report they are not health confident, they can start to think about and explain the reason before the clinician sees them. In addition to the automated information tailored to their needs, the practice can also customize community resources. The idea is to provide patients with feedback, community resources, and something to think about long before they actually come to the office to see the clinician. Although this assessment and feedback system does not appear sophisticated, controlled trials have shown that it works. And from a health services perspective, it is free without any advertising or other conflicts of interest. Clearly, in both real and hidden terms, this method is cost effective. Using the example of the howsyourhealth.org family of internet-based tools, Lynn Ho will now describe how clinicians and patients might take advantage of Saints.
John has emphasized the scientific background of why we ask what we ask in the How's Your Health Saint. This slide summarizes the output that a practice can receive when its patients routinely use a saint. In the left lower corner, you can see that a practice can obtain population-level metrics that are interesting and actionable for the practice. In the lower right-hand corner, the practitioner receives, for the patient in front of her, a summary of the What Matters Index, which may contain highly actionable information about polypharmacy and medication side effects, pain, depression, and health confidence. The deceptively simple How's Your Health Saint is loaded on the back end with many options. For example, a searchable patient registry. But for this talk, I'm going to limit my discussion to how frontline clinicians like myself use these tools to measure and act on what matters to patients. The diagram shown indicates one common approach to using the How's Your Health Saint in a practice. This hypothetical practice has decided to survey all scheduled outpatients once a year, and additionally all follow-up visits from an emergency room encounter. Practices often begin to implement the How's Your Health Saint in a stepwise fashion. For example, they may begin using the process on paper only. They may decide to offer the survey to only people of a certain age group. They may decide to simply get results from the next 30 people that walk into the office. This slide shows White River Family Practice's experience when they implemented, during the first COVID wave no less, an on-paper, truncated version of the How's Your Health Saint that queried only the components of the What Matters Index. The left panel shows what White River Family Practice learned about the needs of their patients with a high What Matters Index score. On the right is shown costly care used from the surveyed patient population 6 months after completing the What Matters Index. This bar graph confirms the ability of the What Matters Index to forecast costly care. White River Family Practice shows the utility of even a simple paper approach to gathering patient-entered data, but far superior to the paper approach are the advantages of an automated computerized saint. One obvious advantage of the computerized saint is that certain responses can be set to trigger automatic direction of the patient to the appropriate web-based educational and support resources. So how can an automated saint process be implemented in a practice? As we said before, one method is to target a particular age group. For example, a practice could choose to target all patients 60 and older. A practice can pre-screen its entire population using just the What Matters Index part of the How's Your Health Saint, as shown in the previous slide. Because the What Matters Index is so short, at most 10 items when custom questions are added, it can be completed in the waiting room, though it is generally desirable to have a patient complete the survey prior to a scheduled visit via a portal or email reminder that goes out with a visit reminder. With early completion, patients have time to think about feedback they received that has been tailored to their responses. Clearly, from a population stratification perspective, patients who have a What Matters index of 2 or higher are at greater risk for future emergency and hospital care and should be managed differently from someone who has a What Matters index of 0. A typical triage scheme is shown in the diagram. The practice would begin to address the issues identified, set up a method to monitor the patient over time, make sure the patient has had a comprehensive Hauser Health checkup, and encourage the use of appropriate community resources and validated problem-solving models as needed. The comprehensive survey and other modules available through hauserhealth.org require more time and are best completed by the patient at home. As each patient uses the Saint, summary practice information is available on a rolling, cumulative, real-time basis so that the practice can monitor how it is doing, make adjustments, and plan for resources based on patient-reported needs. My small practice is able to compare its results to national averages. It is possible and more powerful to work collaboratively with other practices so that the group can become a learning health system. This concept had previously been actualized using the Hauser Health Saint on a national scale by a group of small practices, the Ideal Micropractice Project, who pooled their Saint results so that best practice processes could be shared and bad processes could be eliminated. The current slide shows the summary report for patients in my small practice combined with a colleague's larger practice. Together we have about 6,000 patient respondents. We wanted to see how well we were serving our patients who have financial difficulties. On the positive side of the improvement ledger, the results for our patients are about twice as positive as the national sample. However, the report does show 3 areas of disparities. If we are interested in understanding and addressing the disparity in access to care, we could add an open query to the Saint and patients will be able to describe their reason for the suboptimal outcome and suggest ideas to mitigate this disparity. In other words, we can easily host a virtual focus group. The larger the virtual learning health system, the more likely that possible improvement methods will be discovered and shared. Finally, a practice can use results from the Saint to plan for the type of interventions most likely to be cost-effective for the practice and of utility for patients, aka resource planning. This figure summarizes the relationship between what patients with diabetes said that they needed to become more health confident in relation to their What Matters index scores. In this example, respondents with higher What Matter index scores were more likely to identify a need for professional assistance and less likely to believe that changes in their personal behavior would improve their health confidence. In addition to understanding what matters to each patient now, the practice can plan for future service demands, knowing both the distribution of its patients' What Matters index scores and the verbatim responses of many respondents. A practice having lots of patients with a What Matters index of 2 or higher will need different resources than a practice with fewer high-needs patients. A few decades ago, when we were in medical school, the patriarchal dogma of the times dictated that doctors could rely solely on their clinical judgment to determine the most important focus of what mattered to a patient and prescribe an appropriate treatment. It would be a gross understatement to say that at times the clinician's agenda and the patient's agenda were poorly matched. When deference to professional opinion is the predominant care strategy, unreliable and effective care is often delivered. Luckily, we now have a simple tool, the Hauser Health Saint, which we can hand to our patients to ensure same-page care. During the session, we've explained how we use health confidence and the What Matters Index in real-life practices. We've discussed the more comprehensive technologies available at hauserhealth.org that can allow primary care and many specialist clinicians to practice more cost-effectively in the 21st century. The data that support these patient-centered methods are described in the references. If you have additional questions or comments, please feel free to contact us. We hope you've been able to see how easy it is to measure and act on what matters to patients to improve patient and population health. Thank you for your attention.